Bueno, gracias otra vez por venir. Welcome back. I'm talking about the evolution of our research group. So my lecture is that lecture. I'm going to show you the academic and scientific evolution of a small section of a large research group called AFIPE, Actividad física deportiva o físico-deportivo en poblaciones específicas. This is with an environment of UPM. So I'm going to talk about of our section, the evolution, the academic and the scientific evolution of our section called Physical Activity in Pregnancy is the name of the subject whose students are here. So it's important that I explain you exactly what happened with this group. In 1998, we started our study about exercise during pregnancy in Hospital Severo Ochoa, 24 years ago. As I have already mentioned previously, at that time, most of the clinical recommendation of exercise during pregnancy, adolescent Spain, are based on moral or cultural, even religious issues than in scientific evidence. It's important, it's really important, because obviously this affected of the information given by the health practitioners to the pregnant population. If we were observe our scientific and academic evolution as the movie, the common scene could be as a pregnant woman asking, as a pregnant woman asking to the obstetrician, "Doctor, could I perform any sport during pregnancy?" And obviously, the response of the obstetrician could be, "Of course, sport is healthy, it's perfect, it's magic, it's wonderful sport for you. Sport is healthy." Deporte es sano in Spanish. It's a typical traditional sentence, which the pregnant woman said, "Okay, perfect, because I'm a rugby player and kickboxing practitioner. Even more, yes, I'm thinking about to parachute jumping during my last trimester of pregnancy. It's better for me, perfect, wonderful." Quickly, the health practitioner would have said, no, please, no. This is contraindicated. It's absolutely forbidden for you. So forget what I told you. So obviously the question at that time were, what is the real situation of the recommendation for pregnant population 24 years ago? Even more, what about the best option for exercise? What about the intensity, frequency? What about the start and final of intervention? What about the operating positions for exercise during pregnancy? Many questions about that. At that time, we, as I told you previously, we proposed to respond and to give scientific answers to these questions. And in this situation, from academic and scientific point of view, we wanted to answer the question in order to increase the maternal well-being, even more the health of the fetus, newborn, even child. This is how we started this research trip, this wonderful, this beautiful research and academic trip. And we developed our first doctoral thesis. Miguel, no tengo el puntero, ¿no? Vale. Perdona, me olvidé el puntero. Our first doctoral thesis in 1998, 24 years ago, talking about exercise during pregnancy. It was really, really amazing for us. It was proposed to improve the health of the fetal population. No, solo para apuntar, pero no va lo de apuntar, ¿no? Sí, va. Ah, okay. So this is our subject of in 1998, and after that is really interesting. 7 more doctoral theses, even more. We have right now, actually, currently, 4 theses in actual under development. So this is our situation in the past and currently, and more important, maybe. We during this 24 years, we have managed to establish, it's really important, a solid work team, un sólido equipo de trabajo, a solid work team, by obstetricians, by midwife, and by professionals of physical activity and sports science working together. In our opinion, is the only one, or about the possibility, is the only one to improve the fetal, the maternal, and the newborn health. So it's not easy. I told you previously, it's not easy to join 5 public hospitals in one work team. Even more, our results are generating an important number of publications. Estoy muy cerca, ¿no? ¿Ahí mejor? An important number, dime. Me alejo yo casi. Vale. An important number of articles and two important and fundamental elements. The first Spanish clinical guidelines for exercise during pregnancy. The first Spanish guidelines we have to review this year, maybe the next year. And one more, the exercise program model, universal model, scientifically proven for exercise throughout pregnancy. 2 important elements for us that have an important novelty. The Spanish clinical guidelines have an important novelty, taking in account the operating position for exercise during pregnancy. We have to show to the scientific community what the best options to perform exercise during pregnancy. It's important because we have to review this year, looking for new possibilities. And one more, regarding the model program, we want to give answer to the pregnancy and childbirth situation. We understand that we have to give with this structure to give a response to the process of pregnancy and childbirth. The pregnancy process is a challenge for women, so we have to give a response from academic, scientific, and physical activity point of view. So this is our answer for pregnant population. These contents are ponderated along pregnancy, and the structure of the program is important, and maybe more important is the structure of the session. the structure of the session. It's our interpretation about how we can to apply our philosophy, how we can to make to operate these contents. So this is our structure. We can to avoid the traditional structure of warm up, the central part, and cool down. We prepare 7 parts of the session because this population, pregnant population, need this structure. So we prepare first part of activation, but mental, emotional, and physical activation. After that, aerobic part. After that, muscle strengthening. After that, coordination and balance. Every content that pregnant population need to improve the health or to give response to the challenge that pregnancy is for the woman. So this is our situation, actual situation. And what about the future? We are going right now working on new research lines. We know that it's very, very important to review and improve the clinical guidelines this year with your collaboration, of course. And we would like to publish Spanish clinical guidelines in 3 languages. Spanish, Portuguese is a Rita idea, and English, of course. It's not my idea, it's a Rita idea. It's really interesting for us. It's really interesting for us because we can focus a very big sample if we publish in 3 languages. So this year we have to review the clinical guidelines. In 2 years we have to review the model of intervention with pregnant population. And any more challenge for us. We have to study, we have to know, we have to learn something about sedentary behavior of the pregnant population. Gabi is going to talk about that. Okay, we have to learn of Gabi about that. Sedentary behavior, it's really important. It's a relevant element of the pregnant life. So, more, we have to know about the factors that affect the adherence of pregnant population to the exercise program. Tania is going to talk about the adherence. It's very important for us. Esto es importantísimo que no lo escuchen ellas, pero nos aprovechamos de lo que saben. Para nosotros, for us, it's very important your participation, your collaboration. You know, yes, you have an expertise in that subject. So for us, it's very important. The expectative about you is going up. Okay, so Tania, thank you very much. No, it's important. Tenemos que aprender cómo mejorar la adherencia de las poblaciones a los programas de ejercicio físico. Ese es el key factor. Está ahí la realidad de cómo mejorar los programas to improve the adherence, to improve the quality of data. It's really important for us. More effect of exercise on infant health, of course. Mental and emotional parameters. It's really, really relevant because we know that at the moment the mental and emotional complications and pathologies are increasing at the moment during pregnancy. So it's important to know if some ways of exercise or any program could to improve the situation of mental and emotional parameters in pregnant population. And even more, maybe the most important factor right now, what about the prevalence of pregnant population to the exercise program. Why I put urgent here? Because we could observe that at the moment the prevalence of pregnant, this is Torrejón Hospital. Do you remember Arancha? In Torrejón, sí, es en Torrejón. Well, unfortunately, the prevalence is less than 20%. It's terrible. It's terrible for us, adolescent in Spain. I don't know in United States or Canada. Similar. Bad. Bad than Spain? Oh.
No, it's probably similar.
Similar. Yeah. So it's a problem for us. We have to manage this, to solve this problem. I don't know exactly what we can do, but of course the origin of the problem is on the transfer of research results. I'm going to explain. While the dissemination or transfer of research results has reached to the practitioners, health practitioners, and sport professionals, yeah. Unfortunately, it hasn't reached to the pregnant population. The transfers of result of research to pregnant population is very bad. So the prevalence is very bad. We need to know how to get the connect to pregnant population to increase the prevalence to the pregnant to the program of physical activity. Why? Because if the result of research don't reach all the stakeholders, the process is bad. The process is not worthwhile. It's really important to achieve a big transfer of the research results to the all stakeholders. Health practitioners, of course, obstetrician, midwife, of course, sport professionals, but even more, pregnant population. In our opinion, to improve the intervention means think about how and what, or what and how. ¿Qué hacemos y cómo lo hacemos? ¿Qué queremos hacer? ¿Qué es lo que nos planificamos? What we can do. ¿Y cómo lo vamos a hacer? How we can do. About how, it can only be achieved through a multidisciplinary work team. We believe that we should bring the exercise from the university to the hospital. This is the secret. To bring the exercise program to the university, from the university to the hospital. In our opinion, is the best option. Llevar los programas de ejercicios a los hospitales y no al revés. Es la forma de transferir más adecuadamente. It's really complicated. If we don't to bring the exercise programs to the hospital to achieve increase or to growing up the adherence of the pregnant population. About what we know that we have to review the contents of the program, of course, and the activity that make up the session. This is the content. This is what we want to do. We think that the best option for the pregnant population around the pregnancy is this content. Okay, how we can to make an operation to transfer the content? Okay, in a session. So for the next month or years, we are we will to work to get to improve the activities, the possibilities of the 7 part of the session. The first part is the activation. Okay, so we are looking for new possibilities. We should to find new possibilities to get a mental, emotional, and physical activation. But there are many other possibilities. What about the second part? What is the second part? Marcos, ¿cuál es la segunda parte? Aerobic. Okay. The same one. We are looking for new possibilities. We think that the activities that we planned are the secret to successful of the program. More activities. There are many others possibility. If you are thinking right now, I'm sure you are thinking in many possibilities. Okay, third part. Entrenamiento muscular, fortalecimiento muscular in Spanish. Fortalecimiento muscular. If you say fortalecimiento muscular, people think that is hypertrophy. No. I'm talking about light muscle strengthening for pregnant population. It's possible. Of course it's possible. For sure. We only to looking for what area and how repetitions and intensity, operation possibility, and we can do what we want. Okay, more part. Coordination and balance is a very attractive section of the session. Okay, more activities. Look at Christina. Good professor. Christina is not pregnant yet. By the moment. Okay? And the final part, stretching and relax. It's important to invent, to create activities. It's, of course, our obligation as a professional of physical activity and sport science. We have to create new possibilities. We have limits. Of course, we have limits. The Spanish guidelines, clinical guidelines, show us the limits. With those limits, we can improve and we can create new possibilities. More stretching and relax. There are many other possibilities. We have to think and create. Pelvic floor. We have to looking for different positions and possibilities to work in pelvic floor. Tomorrow, Kari will go in. Kari is going to talk about the pelvic floor and a specialist. Vale. Susana, la especialista mundial en pelvic floor. La tenemos mañana aquí. Is maybe the most important researcher in pelvic floor around the world. Yeah, I'm sure. And the final talk, la charla final in Spanish, charla final. Final talk, it's relevant part. Why is the relevant part? Well, because the pregnant woman in that moment is the moment in which the pregnant population puts on the group all the sensation, perceptions, ideas, problems, complications. Exercise is a social and cultural mobile for emotional and mental issues. Okay, so this is the future lines of investigation. Okay, my friends, thank you very much for your attention.
Hello to everyone. I'm Irene Fernández Huigas. I'm an obstetrician from the Hospital of Torrejón. And I'm going, first of all, thank you for the invitation, first to this talk. And also thank you for the invitation to work with your group here in the INEF University. And what I'm going to try is to make It's a little like a resume of everything. Talking about one trial we performed in 2014 with the Rubens Barakat group. So I hope you understand everything we've done, because it's very quickly what I'm going to speak about. First, say that we all know the benefits that exercise can have to everyone. We all know, adulthood and childhood, we all know. But when it comes to talk about pregnant women, we all have our doubts, like if it's going to be safe for the mother, it's going to be safe for the baby, is there going to be an impact in the pregnancy or in the delivery? So with these questions, we started a work at a randomized trial just to try to ask this question. The main objective was the weight gain, but then we tried to answer lots of more questions we all have when we think about pregnancy and exercise. What we did is to pick up pregnant women with low-risk pregnancies, and then we randomized them into groups. The first group was the control group, and they were asked just to live their normal life and try not to join any educational exercising during pregnancy, so they could be a good control group. At the end of the pregnancy, they were asked about what were the exercises they were doing at home, if they at the end had any exercise, and it was measured also because it was something we had to know. And the other group was the intervention group. At the end, as you can see, we had 69 in the intervention group and 51 in the control group. The exercise was 3 times per week, 16-minute session, and they started around 14, 16 weeks, the exercise, and they went all through the pregnancy. To be analyzed, we wanted to have a 70% attendance to the intervention. At the end, we only had 41 women that really went to more to that 70% of the intervention. And we meant to be a low to moderate intensity in the exercises, so they will all wear monitors to see that the heart rate was not higher or lower than that. And the sessions went like as just Ruben said, and as you can see there. Well, all the women, both groups, had the routine care of the pregnancy, the routine care blood tests, and also the visits with the obstetricians. In all the visits, they had an ultrasound scan, a complete ultrasound scan with a fetal cardiac also scan, and they all have the weight measured, blood pressure, everything you can think you can do in an appointment. And they also had an appointment 6 weeks postpartum. What were the results? Well, first, the weight gain. What we saw, it was actually what it was already written, and we said, well, it was real. The exercise group gained less weight than the control group, and the postpartum weight loss, that's not many in literature about it, it was also higher in the exercise group, okay? Then, we looked up at the blood pressure, and this was quite surprisingly, because it's not quite equal to what the literature say, and we don't know why. We saw, as you can see, well, the differences, most of them weren't significant at all, but as you can see in the 28 weeks, there's a higher level of the systolic blood pressure in the exercise group, always in the normal range. That's important. This, we think it was found by chance, but we really don't know. As you can see in the graph, maybe we could say that the exercise group has more stable blood pressure, but we don't know. So further research is needed, because maybe it's just by chance, and that happens in trials. But we think we have to look forward in larger trials to see if there's something there. We also saw the blood test at the routine blood test in the women, and we wanted to see what happened to the glucose. As you know, glucose is important for the fetal development, to the fetal growth and the fetal well-being. And when you perform exercise, glucose is important also for the mother's muscles. So you can think, well, there could be a lack of glucose for the baby if the mother is doing exercise. What we saw it was that at the fasting glucose, there were no differences. And we also saw that after the O'Sullivan test, there weren't differences between the groups, okay? And it's important. I want to say that at the O'Sullivan test, there's a previous work that says the opposites, and that in the control group, in the exercise group, the levels of the O'Sullivan test could be lower than in the control group. We think the difference between the two trials could be that we perform the O'Sullivan test not fasting. It means that mothers come with a breakfast before, and then maybe that's the reason we haven't found that difference. It is true that most trials, they talk about that glucose is, that diabetic women during pregnancy that perform exercise are going to handle better the diabetes, okay? And we only had 3 women having diabetes during pregnancy, so we couldn't compare at all at that level, okay? We also wanted to see what happened in the liver and in the kidney, as there are 2 organs that during pregnancy have to adapt to the pregnancy, and any injury in them could be very harmful for the pregnancy. And we know that the woman has to adapt also, the liver and the kidney has to adapt to exercise. So we wanted to see what happened there. I want to say that it was the first time someone looked up in the pregnant woman these two organs, okay? So we didn't find any difference. That's really reassuring for us. But it's true that it's very little, the sample, so we have to keep on researching here. Okay, with larger studies, that is the main problem here in the trials with exercise and pregnant women. We also looked up at the liver outcomes, as the literature is quite controversial. Some say that exercise can make the baby smaller, or can help to not having large babies, or that can provoke, and that's the major concern, preterm delivery, or lower up the age of gestation that you are going to delivery. And as you can see, we looked up of everything, and there weren't any differences between groups, and this is also quite reassuring. It is true that the sample is very short, but it's larger than most of the previous literature, so it's quite reassuring to see that there are no difference here. For the first time, we also looked at the fetal cardiac function. We know that in adulthood, the person that is going to perform exercise will adapt his cardiac function. And we wanted to see if the baby does it too, because when there's a stressful situation like fetal growth restriction, for example, we know that the fetus is going to adapt the fetal cardiac function. So we wanted to see, it was just to see if something happened. Also, it's a small sample, so we didn't find any important significant differences between groups, except at 36 weeks, where the ejection fraction was slightly higher in the exercise group. And that could be good, actually, but we don't know if that was by chance only found. So larger studies are needed to see if the baby is going to be adapting something in his cardiac function that in the future will help him, not just in delivery, but in the adulthood, to have a better cardiac function. But we need larger studies. We also looked up to the Dopplers, because us as the obstetricians use Doppler to see the fetal well-being. When a baby is in a stressful situation, like fetal growth restriction, we know that the Dopplers change just to adapt him to that situation. As exercise can be a stressful situation for the baby, we wanted to see if the baby was adapting somehow to that stressful situation. We checked up at 20, 28, and 36 weeks, and we didn't find in any checkpoint any difference between the Dopplers. But then we wanted to see if the evolution of the Doppler was different between the groups during pregnancy, and there we found a difference in the PI of the umbilical artery. As most of you are not obstetricians, I would say that when a baby is in a very stressful situation, is going to try to high up the PI, okay? And it could be as high as being harmful for him, okay? Just to explain more or less what we are talking about. More complicated than that. But okay, so what we saw was the PI started at 20 weeks, slightly in the exercise group, slightly higher, not significantly higher, and that's very, very important, okay? As you can see, but as you remember, this woman started exercise like 5 weeks ago, okay? It was slightly higher, not significant. And all through the pregnancy, they tended to go low and ended up a little bit lower, not significantly different. That's very, very important, okay? And always in a normal range. So this reduction was different between groups. We don't know if that's, again, only by chance that we found it, but it could be important, okay? Before, there's a trial very similar to us that the Ruben Barakat group made, and they had similar exercise in both groups, okay? And at 33 weeks, what they did was do a cycling test to both groups. And then they measured Doppler before and after the cycling test. And they saw actually that the exercise group didn't have an PI in the umbilical artery as high as the control group. Maybe we are seeing the same thing here, okay? But again, larger studies are needed to really know what is happening there, but something's happening. And it's a good part, okay? That happens, it's good. A high PI, not that good. Low PI, better, just to get that. So in conclusion, when we finish this study, what can we say? Well, that in low-risk pregnancy, we haven't seen in high-risk pregnancies, so we don't know. Regular, supervised, mild to moderate exercise program during pregnancy at least does not deteriorate the fetal or maternal well-being, and that's a lot, okay? And even more, we are thinking that probably it has some very good points during pregnancy that we still have to really ensure, to really demonstrate that that really happens. But at least it's not bad. So take-home message. Regular exercise during pregnancy is safe for both, for mother and for the baby. So let's go on, okay? And very, very important, we have to keep on trying to discover if there are some really nice points on doing exercise. And for that, as Ruben said, very, very important to work together, okay? Work together, obstetricians, with specialists in exercise. So if we don't do that, we won't get any chance of knowing what is happening there. So thank you very much.
Hi. Voy a empezar diciendo en español que yo, como sabes, era nativa en inglés, pero después de pasar el COVID, oye, algo ha pasado aquí. Entonces si hablo mal inglés por el COVID, no es porque yo hablara mal, ¿eh? So first, thank you very much, Ruben. Like always, it's a really pleasure to be here. It's an honor. Thank you. And yeah, barriers and fears about the physical activity during pregnancy will be my conference today. And what are you afraid of? Fears represents the emotional behavior response to the perception of danger, leading one to avoid the threat for survival value. And during the pregnancy, there's like explosion of fear. If we look in websites, for example, this is a Canadian website about the common worries during pregnancy. Used to be, for example, my baby have birth defect, miscarriage, baby be stillborn, will the drugs or alcohol I have before I was pregnant affect my baby? Or have I been exposed to or done something that could hurt the baby? This is a USA website, top pregnancy fears, and it's almost the same. Birth defect, miscarriage, too much stress, and eating sushi, that I was really surprised. Go before the breastfeeding, so interesting. And number 9, heavy lifting. What happened if you see this photo? The first thing you think is, now I need your participation. So raise the hand if, wow, we should not doing this. So I not recommend doing this. So raise your hand. Oh, okay. Not sure? That's cool. Not sure? Okay. Okay. Number 3. That's cool. Everybody needs to do it. Okay. What about climbing? So raise your hand. This should not to be done. So not recommend.
In the gym or for real?
For real. For real? Not recommend? Okay, good. I'm not sure. Okay, yeah, absolutely. Everybody needs to do it. And it will be the same with boxing. So I have to tell you that last week I'm gynecologist. I work in Sweden. So I saw the photograph to my colleague, and it was like a war after this, because everybody has a different opinion about this. Even if we know, but there's another kind of knowledge here, because it depends our fear and belief. Fear is an emotional response generated during dangerous or painful experience. So fears is related to our experience. And belief are defined as conviction of the truth or proposition without their verification, and such are subjective mental interpretation derived from perception, reasoning, communication, or Google. There's an interesting systematic review. It talks about attitudes and barriers. I'm not going to talk a lot about psychological or psychosocial barriers, because it's going to be discussed in another conference. But in this systematic review, 45 students, there's quite a lot of studies about the safety. And conclusion was at the intrapersonal factor of maternal health and well-being, pregnancy symptom, and safety of self and baby were most frequently identified as barrier and enable to physical activity in pregnancy. So this is really important. And now I would like to talk about a very common problem in pregnancy that has really a lot to do with the fear. This is the lower pain and or pelvic girdle pain for me. And I've been a gynecologist for 20 years ago, and it was really new. We know that lower back pain and pelvic girdle pain is really common problem. About 40% till 78% have this problem on the pregnancy. Pelvic girdle pain refers to pain in the pubis and sacroiliac articulation joint. What happened when we have low pain, we try to avoid anything that is recognized as intensity pain. Fear of pain may cause constant avoidance of the mentioned situation after a while. While this type of behavior is absolutely normal, it can lead to an inadequate understanding of pain, provoking fear, anxiety, and finally leading to fear movement. And this can do it that the inability to perform daily activity, physical activity, or even normal social activities. Factors affecting the pain during the pregnancy can be related to physiological and hormonal change. We know about it. But also stress and even, it's quite surprising, lack of job satisfaction. This condition, low back pain, pelvic pain, it's observed around the world. Most society and countries have. And there's different treatment, including the rest, physiotherapy, acupuncture, lumbar corset, etc. Physiological variables, including attitude, belief, cognition, anxiety, have more effect on the risk factor of back pain compared to biomedical factor. And we know that several psychological, social, and cultural factors can play an effective role in the progression and persistence of pain, syndrome, and response to treatment. So it's not a mechanical problem here. There's some studies, and the pain-related fear is more debilitating compared to pain itself. So the idea of pain is worse than pain. There's a lot of studies about the another type of pain, fears, avoidance, belief, and translation into clinical practice. And we know that for patients with low back pain, excessive fears, avoidance, belief result in an obstacle for recovery. So then when they start to have pain, it's really difficult to stop the cycle. And when we treat this fear, it will be and really improve of the symptom of pain. Fears can be classified into three categories: misinformed avoider, and this is a typical person, pregnant woman who have not good information. Learning avoider is like Pavlov duck, or affective avoider, that is a mix. How we can know if a pregnant woman have a lot of fear? There's a questionnaire that we can use, fear, avoidance, belief questionnaire, who was developed based on theories of fear and avoidance behavior. This is really interesting or really useful in the practice. This questionnaire has been used in studies like this. The relationship between fear, avoidance, belief, and pain in pregnant women with pelvic girdle pain. And this study is really interesting. They found that fear, avoidance, and catastrophe belief in women with pain can be predicted. And this offers an opportunity window to do something with this, because if we can identify in first trimester of gravidity that they have fears, we can prevent the fears and the pain and the inactivity. There's another study in Stockholm that conducted on women in the 1978 weeks of pregnancy, they found that pregnant women with lumbopelvic pain have higher level of negative thoughts. So it's the same. Have fear, no movement, and will explain the inability of the patient to be involved in physical activity. So I hope that this know of fears and belief provides valuable insight for health professionals to help inform the design of physical activity. It's something that we must to think about when we design intervention. Yeah, I stop here.
Okay, so I'm Christy Adamo. I'm from the University of Ottawa in Canada, and I want to thank Ruben very much for inviting me. I really wish that this meeting would have been like last week, so I could have seen Real Madrid beat Man City in the Champions League, but unfortunately we're here. All right, so we're going to change directions a little bit, and I'm going to talk about the placenta. So the obstetricians in the room are probably quite familiar, but everybody else might not be. So hopefully this won't be too hard to follow. So I like to say that the placenta is the organ that everybody in exercise physiology ignores. So we know that exercise is beneficial for almost every organ system, but we know very little about how it affects the organ of pregnancy. So my research in my lab is very interested in something called the developmental origins of health and disease. So what that means is that what you're exposed to in pregnancy plays a big role in what might happen down the line. So there's fetal programming is sort of what this is called in the DOHAD world, so that an exposure in pregnancy can either negatively or positively impact the fetus down the line. So my team, we call ourselves the Placenta Squad. We're quite interested in that organ. And we're interested in exercise as a beneficial exposure. So while as most people in the DOHAD field, they study diseases of pregnancy, or they just study unhealthy things that happen during pregnancy, we are actually very interested in exercise as a healthy behavior. So we know that exercise is very good for almost all bodies, and it is very important for various aspects of pregnancy outcomes. So not only does it reduce the impact of various disease states, but it's also really important for fetal outcomes. And this is what we're interested in. So if you're interested in this paper, this was a review paper written by a few of my students. So physical activity is good for mom, good for baby, as Irene just let us know, or not bad for baby. I suppose that's a better synopsis of what you said. But how does it improve pregnancy outcomes? What are the underlying mechanisms by which physical activity might optimize fetal growth and development? So how can physical activity optimize fetal outcomes? It has to be likely through the placenta, because that is the communication between mom and baby. It is not a direct line. There is the placenta in between. It is the barrier, and thus physical activity must somehow be impacting the placenta, thus to impact the fetus and the fetal outcomes. How does it do this? Can it be doing it by changing the maternal milieu, or the circulation, what is circulating through the bloodstream? Better glucose control, better use of nutrients, lower inflammation, things like that. These are all beneficial effects of exercise, we know. By changing the placenta form and function, increased functional capacity of the placenta surface area, meaning there's more room for exchange of nutrients and oxygens, improvement in maternal blood flow, enhanced perfusion. These are all potential impacts through changes in the number of placenta transporters, receptors, and key signaling molecules, which is something my team is very interested in. So for those of you that don't know, the placenta has a maternal side where it is basically attached to the uterus, and then it's tethered to the baby through, let me see if I can do this right, through the umbilical cord. So the baby is tethered to the placenta through the umbilical cord and the vasculature, and this is the maternal side, which is essentially attached to the uterus. So this is essentially what the placenta looks like. And within the placenta itself, there is this vasculature. So we have this villi, and these are the vessels. So we've got the maternal side here. So maternal blood flows through here and interacts with these villus trees. And therefore, this is where the nutrient and oxygen exchange is taking place. And subsequently, this is passed on to the baby. So the maternal blood flow and the fetal blood flow never touch. It is happening through the organ of pregnancy. So this is why I say this organ has to be impacted by physical activity to thereby impact the fetus. Something must be happening at this interface. Okay, so the placenta is imperative for transporting oxygen and nutrients. These are non-negotiable needs for survival. Without this, the baby will not survive. So how might exercise or physical activity be impacting the placenta? We know that it's positive, but how does it do so? What is happening? I wish I could give you all the answers today, but I'm going to give you some of the stuff. I'm going to tell you about some of the things we're doing in our lab. So our proposed mechanism, or what we're thinking is happening, is that we know before exercise, so we've got our uterine artery and our uterine vein and our placenta in here, and so we've got a certain amount of blood flowing to and from the placenta. During exercise, blood flow needs to be redistributed. All of you in exercise physiology know that blood flow needs to be redistributed. So if you're going to be using your skeletal muscle is going to take the lion's share of the blood flow. So we project that there's probably a slight reduction, not a total reduction, but maybe a slight reduction to the placenta, which then is amalgamated, where afterwards this is improved. And because you have this slight reduction, that might stimulate angiogenesis within the placenta, so the creation of new blood vessels. Sorry, I'm competing with the construction here. But so this is what we think is happening. So this exposure, slight hypoxia for periods of time, might lead to changes in the placenta that are beneficial. This is similar to what happens in other organ systems during exercise, but specifically in pregnancy, this is our theory of what might be happening. So we wanted to know, so there's something called placenta efficiency. So the obstetricians in the crowd would be familiar with that. There's multiple ways that placenta efficiency can be measured. These are just a few of the ideas as to how it can be done. So placenta efficiency is essentially a surrogate marker of the placenta's ability to exchange nutrients and gas to support fetal growth. So some of the fears with regards to exercise in pregnancy, it's going to impact placenta efficiency. Exercise is going to negatively impact placenta efficiency. This has been commonly one of the fears. We looked at this in our patient population in people that were participating in one of our studies, and we found that there's no difference between women who are highly active during pregnancy versus those that are not in the measures of placenta efficiency. So that shouldn't be a fear. So there's not in these we call very bold measures of placenta efficiency. They're not molecular measures. We call gross measures of placenta efficiency. But there should be no fear. There's no impact of physical activity on these. So as Irene, you were saying, we had hoped to find something positive, like beneficial, but finding no difference is actually something very good. So in our placenta study, we're looking at I'm not going to talk about these aspects, but we're looking at nutrient transport, the impact of physical activity on the transport of nutrients through the placenta. We're interested in angiogenesis, or the production or the vasculature, the development of the vasculature in the placenta. And we're interested in circulating factors that might affect organ systems, including the placenta. So things like myokines. So you've probably heard of myokines, which are cytokines, which are released from the skeletal muscle. And we're interested in something called extracellular vesicles, which I'll talk about briefly here. So nutrient transport. So we need to transport glucose, amino acids, and fatty acids through the placenta to the baby. There's all sorts of transporters that do so. Our team has been quite interested in looking at GLUT1 for glucose, SNAT2 for amino acids, and fatty acid transport protein, or FATP4, FATP4. So these are various transporters that we've been looking at when it comes to physical activity. I know you're probably not all molecular biologists, so I will quickly illustrate what this shows here. So this is recent work by one of my students, Kelly. These are Western blots on the left-hand side here. So these are FATP2, GLUT1, and SNAT1. So these are different nutrient transporters in the placenta. All these little bars are telling us here we're looking at protein expression. Western blots tell you how much protein is expressed in that tissue. So we were looking at placenta tissue from active women, women who are active during pregnancy, and women who are inactive during pregnancy. Summarized here, we found no difference in GLUT1, no difference in SNAT1, but we found a difference in protein expression in FATP1. And the difference between our active women and our non-active women is significant. So the active women were exercising for about 55.5 minutes a day, which is quite a bit for pregnancy, whereas our non-active women were only active for about 4.7 minutes a day. So a very stark difference between these two groups when it comes to activity. Beyond that, we wanted to look not just at protein, we wanted to look at where is the protein in the placenta, where is it located? So this is immunohistochemistry. And what this is we basically took a biopsy, or we took placenta tissue and we have put it on a slide and we have put antibodies on it in order for us to view various aspects, to view some of these nutrient transporters. So in this case, the top panel here, we've got our active and our non-active, and we're looking at FATP4. So what might not be inherently obvious here is actually there is more expression here of this FATP4 in certain areas of the placenta. So you can see it on the outside area. These are maternal vessels here, and there's fetal vessels inside. But anyways, this is the vasculature of the placenta. So using immunohistochemistry, we found that the FATP4 and GLUT1, that there are differences in the physically active versus non-active with regards to our staining. And where it was located was different. And in GLUT1, 2 here, while we didn't find differences in protein expression, we found differences in where this is located in active versus inactive women. So it might not just be the amount that you have, but it might be where it's located that might change the exchange of these nutrients. Okay, so I won't go into too much detail there. As I told you, angiogenesis is something that we were interested in as well. And so one of my postdocs, Jayanta, was doing this work where he looked at protein and mRNA expression of very important angiogenic factors. So VEGF and its receptors, as well as placenta-like growth factor, these are important factors when it comes to angiogenesis. All right, so that means the production of vasculature in the placenta. And what he was able to find is that it was significantly higher, that the protein and MR expression of VEGF and its receptor VEGF1 or FLT1, that they were different in the active women, that they were expressed to a higher degree, which would indicate maybe that this exercise is stimulating the production of more vasculature in the placenta, which would be beneficial, which means that exercise is actually allowing for the surface in which there's exchange between the maternal side and the fetal side to be optimized, that it might be better, and thus the fetus is not compromised, but in fact is benefited based on this aspect. Similarly, we wanted to also look at the where it is expressed in the placenta, and this is again more immunohistochemistry where we were able to find different staining patterns. So VEGF, there was intense staining in the active group. So in this case, this is the active group in most cell types in the placenta, and it was faint in the inactive. So there was more expression of this in the active placenta. There was nothing really exciting with VEGF receptor 1, but VEGF receptor 2, the staining was also more intense in the more active group. So again, indicating that maybe where these are located in the placenta might be of importance. Lastly, we're interested in how myokines or other circulating factors might be impacting the placenta. And so we know that myokines released from the skeletal muscle can have an impact on all sorts of systems of the body. What we don't know very much about is how they might impact the placenta, as well as small extracellular vesicles. Has anybody heard of EVs, extracellular vesicles? This is a really popular area. Lots of people are studying this right now in exercise physiology and elsewhere because these are small vessels that basically are sloughed off from various tissue types, and they can carry information inside a long distance. So they can have an endocrine effect or a paracrine effect. And the thought is that the cargo, or what is contained in these vessels, might be signaling other systems. They might be signaling other organ systems, they might be signaling the placenta, and the information carried within might be carrying a message that changes the behavior of that system. So the extracellular vesicles are a really hot area of study right now.
Chicas, ese no es el índice de pulsatividad. Is there no pulsatility result of that? No. Okay.
Subsequently, it's not easy to study these, though. You need to isolate them from human, like we were using maternal serum, and it is quite an intricate process. You have to have fancy centrifuges. You have many fast centrifuging steps in order to isolate them. Then you have to be sure that you have the right size and the right version. Some of this work is incredibly challenging to do. I'm trying to show you that it's simple, but it's not. This is a lot of hard work. But suffices to say, we wanted to look at whether or not the placenta could receive a message from extracellular vesicles. So we were able to isolate these EVs from serum from exercising pregnant women, and then we exposed in a cellular model in our lab BWO cells, which are a cell model of placenta cells. We exposed these cells to EVs that were isolated from pregnant women, and we wanted to see whether or not the placenta could internalize them and take these up. So this might be a communication strategy from mom to placenta, subsequently to baby. And we were able to show, one of my students, Shahiba, was able to show internalization of this, so that these extracellular vesicles that we isolated from exercising pregnant women could be taken up by human placenta cells. Again, this is a cell model. These are not cells that we've taken from pregnant women. This is a culture model, an in vitro work. But we are the first people to have shown this. We were the first people to have isolated these extracellular vesicles from exercising pregnant women, and to see if they have a potential to communicate, to talk to the placenta. Very preliminary work. We want to follow this up, but this is novel and new work to show that, yes, this might be a way that exercise is therefore impacting the placenta. Very, very new work. Not a lot to say yet on that. So I want to thank you guys all very much for listening to my talk today. And that's what my lab does, an eclectic mix of things. So if you're interested, love to talk to you about it more.